Thank you. Thank you very much. And good afternoon, everybody. And I just can't thank enough to invite me for this lecture. And I hope that I won't be too narrow in my description, because what I'll be talking more or less about a very, very select group of newborn babies, but I'll walk you through as we go. And as you can see from the title, my most important aspect that I'm going to concentrate is on quality improvement, because that has been the forefront of activity that we have been doing in the last 15 years. So what and why of quality improvement? Review our national experience, and I'll take you to the international arena as to how that has spread to other countries and what other countries are doing, as well as to understand some of the benefits and challenges that go along or come across as you go through this journey. So I know many of you are not neonatologists, so I'll start with a case, a 31-year-old young woman who in her first pregnancy, everything was going fine. She was happy that she got pregnant, and suddenly labor started. And she delivered a baby at 25 weeks gestation of 700 grams, which the baby would needed intensive life support. And just to give you a perspective, this is what we are talking about here. This tiny little, you can see the size of the baby equivalent to the size of the hand of an adult on the side, and baby needing intensive life support. So what happens? This baby spends next 4 months in the ICU, needs breathing support for 3 months of those 4 months, needs nutrition support for half of the time, had 2 infections, had a minor surgery, one surgery, one minor bleed in the brain, and at 3 years, looks like this, with mild to moderate learning disability. But the important piece of this whole puzzle is that just the neonatal stay costs $120,000. So this is a very high risk, very high resource intensive cases that we deal with, and that's what I'm going to talk to you in the next few slides. And it is important because if you look at globally, more children will die for being born soon than AIDS, malaria, or diarrhea. This is the data from the global health. So this is not a 25-weeker, but being born preterm is a major, or being born low birth weight is a major factor that affects many, many babies worldwide. And to look at back to how neonatal care has evolved from, we were probably 1960s, we were nothing. And it started evolving. In 1970, we had some devices that developed CPAP, and some of the babies were ventilated. In 1980s, we learned that if we give mother antenatal steroid, it improves the outcome of the babies. In 1990s, we have another molecule discovered, surfactant came in place, and that improved the mortality significantly because these babies, when they're born, they're struggling to open up their lungs, and because they are deprived of surfactant. In 2000, we became more advanced with ECMO, nitric oxide, and in 2010, we started to learn, yes, we are having more babies surviving, but the more babies are having problem as well. So we started treating them gently. We started avoiding mechanical ventilation to support them with all other resources that we can, and started involving family because that's what. And during that period, many randomized studies also started to evolve. But what has happened in the last 10 years or so, there is no new molecule that has discovered. Nothing has discovered. So people learn that we need to do better what we know, and we need to do consistently what we do. And that will lead to improvement. And that is the basic concept of the quality improvement. And we embrace this concept initially at the local level. Because if you look at the different centers, they were reporting different outcomes. And there would be centers which will be showing the outcomes which are at the bottom fifth, centers which will be showing outcome at the upper fifth. There is nothing you could do to these centers unless they improve their clinical care. They have to work on improving their clinical care. There is not much you can do at the upper end as well. You have to be very innovative to improve their care. But what quality improvement is bringing everybody to the middle, like reducing the variation in the outcomes across the site. But doing so, we don't want to bring the sites which were sitting here to bring them to the left. What we need to do is to move the whole concept, whole curve to the right so that everybody improves, everybody becomes consistent, and everybody improves in a better way. So I'll walk you through to show you that this is what we think we have achieved, and I'll let you be the judge of it. So first, to go over the national experience. So we developed this on the platform of Canadian Neonatal Network. So this was a network established in 1995-96 by Dr. Shu Lee. When initially we started, his aim was to let's learn what others are doing and what are the outcomes at the local level. And it was a mission that we learn from what we know, educate others, as well as go not only in Canada, but go internationally, involving not only medical field, but paramedical field as well. So I'm proud today to say you that there are 31 level 3 neonatal intensive care units in the country, and all 31 are part of the neonatal network. So we get data on each and every baby that is admitted to any intensive care unit across the country on a daily basis. So that forms a big platform that we can do a lot of activities. Now, one would argue that are they all similar? Are they all same? No. We have units which care for less than 100 babies, and we have units which care for more than 1,000 babies. But we wanted to bring all of them together in the quest of reaching to a point where everybody say, it doesn't matter, I'm admitted in this hospital or this hospital. And it all started with our first paper in Canadian Medical Association Journal in 2002, when there were 16 units participating, and you can see the difference in mortality. It varied, the odds ratio varied from less than 1 or less than even 0.5 to more than 10. And it was a public outcry. There were a lot of letters written in response to this paper, and everybody said, tell me who is M and J. I want to go to M and J. I want to take my baby to M and J. We could not publish the name because of the confidentiality reason, but that gave us an idea that why is this? Why is this happening, and what can we do? And that's where we do a lot of activities. Our core is the benchmarking and trend evaluation. But what I'm going to concentrate today is on the quality improvement aspects. I can talk about other things in the question answer if anybody has any question. And we embrace this from this concept. We wanted to bring the guy who is sitting here to up and not to pull anybody down. And I'll show you that what we have achieved in that aspect. So what we coined this as evidence-based practice and quality improvement, in quality improvement. We call it EPIC, and I'm on behalf of hundreds of people across the country, I'm presenting what I'm presenting to you. But what we did was developed a conceptual model in which we had input, process, and output. This is what the fundamentals of the quality improvement. You need data, you need information, you need somebody to tell this is the best way to do according to the existing evidence. So we did a lot of reviews on how and what to do when we are taking care of the babies. We processed all the data, we analyzed all the data on an individual hospital level as well as a global network level. And we created output reports that can be sent to the sites so that they can look at where do they stand in relation to the entire network and where do they have to work for the next steps to take it. We promoted a huge amount of dialogue between the teams. We had annual workshops for last 10 years now. We shared and evaluated data. We shared amongst ourselves. We shared best practices. If somebody develops something that helps mothers to give milk to the baby in an efficient way, we took those videos and gave it to all 30 sites so that they don't have to create new videos. They can use that. So what I'm going to show you that journey over 4 study periods that we allocated, we worked on, and we are not putting our guards down, and EPIC 4 is going to be launched in next February. So what we called EPIC 1, this was, we did it as a cluster randomized trial. As you can imagine, in 2002, an early part of 21st century, it's still no, show me the evidence, and evidence is only randomized controlled trial. So what we did was we asked 6 units, what actually we did a lot of interactions. emails, conferencing, video conference, teleconferences, shared objective, some face-to-face meeting, local face-to-face meeting, site visits. We provided continuous flow of data to individual sites. Say, look at your data and decide what you want to do, how you want to do, what are you doing. We gave them the list of best practices that this is how you should do. But we did not bind them that you have to go and follow each and individual practice because there was not 100% evidence behind it. We tracked their data and continuously fed them data back so that they can look at their data and understand and learn. So there were 12 NICU which agreed to participate at that stage. So 6 were randomized to reduce infection, nosocomial infection. 6 were randomized to reduce chronic debilitating lung condition called bronchopulmonary dysplasia. And 5 NICU told us that we don't have resources to work. We said, okay, well, you stay as a control. So we'll watch what is happening. And with that, what happened, the infection group worked on infection, reduced infection by 1/3. But the good thing, because infection was reduced, the debilitating lung disease was reduced too. So that was a byproduct, because if the child is infected, the inflammatory material causes the lung damage. So that helped in that aspect. And the group that was working on lung disease reduced their lung disease by 15%. Importantly, there was no change in the control group. They just stayed in their incidence. So for this project, what we did was we invited teams from each site to come and have a 2-day workshop to learn how to do quality improvement, how to go back, how to create teams, and how to work within their units so that they can learn and they can disseminate. So it's not a one-person job, it's a team. So local teams were built at each site. So we learned that we can get benefit from one outcome to another outcome. It is a cost-effective way of reducing adverse outcomes. So we were happy, and we said, well, now we need to embrace the third concept. We are not coming to do work, we are coming to do good work, and we are coming to improve the work that we are doing. So we were very happy, and we left it, and we said, oh, wow, this is great, this is going great. So everybody, other hospitals came to us and say, oh, tell us what you did, and we will just do it. So we said, these are the practices that people did, because there was nothing we could point out that this is what will reduce infection or this is what will reduce BPD, because it was multitude of practices that people changed. So we said, this is the list. Now more sites were interested. Oh, wow, you can do it. We want to be part of it. So we invited them. We put them in a team room. We showed them this is what we did and said, okay, go. And we thought that it will just continue to have that spiral effect without any adverse events that we will notice. And we said, we'll look at the data after 2 years. So there was no intense monitoring, no intense telling people what are you doing, no intense feedback on their data. And we said, well, because we were happy, we'll see you at the end of 2 years. And you can see the sites which immersively engage continued to do the improvement. The site which was given a piece of paper, these are the good practices, nothing happened. They can read the papers, but they did not change. So quality improvement is not just reading and understanding, it's immersive engagement and doing things. So we learned that you have to do it to understand it, that what is happening. So then we said this cannot happen, this cannot be let go, so we launched a 5-year program where we wanted to reduce a lot of other morbidities, and not only morbidities, we wanted to see that babies are better at 2 years of age, at 5 years of age, not just reduce the morbidities. So we targeted some high-risk babies and targeted a lot of morbidities. We created a virtual reality platform where people can put their practices, put their practice changes, so other unit can see and don't have to reinvent the whole wheel. They can just take that checklist and implement, modify, and use it. So a lot of interactions, a lot of workshop. Just to give you one example, this is the hospital which was worried because in their hospital, by the time the baby is born to by the time the baby gets surfactant, there were 14 steps they have to go through because surfactant is in the pharmacy cabinet and pharmacy is away from where baby is being born, all those things. And it was recognized at that stage, the earlier you give, less the damage you do. So we asked them, you go and tease out this process. What happened? How it happened? how babies get surfactant and what are the issues in your program. We asked them to review the literature and find out how can you tackle pharmacy and baby together so that the surfactant is in the next door freeze where baby is born and not wait for the pharmacist to approve. And this is what happened, 3 steps. So this is what the locally they do. We didn't tell them to do. They identified that this is their problem. By the time their babies were getting surfactant, it was 4 hours. And they aimed for 30 minutes. And this is what happened over time when they started doing the quality improvement. So this is just one example of several such initiatives and activities that people did. So what we found at the end of those 3 years from the neonatal perspective, that for these high-risk babies who are at a significantly high risk of adverse outcome, we reduced the odds of either dying or having severe morbidity by 37%. That's a significant. 1 in 2 more babies were going home without any abnormal morbidity developed during their course. But we also learned that we made majority of improvement in 26 to 28 weeks, not in even tinier babies, which were 23, 24, 25 weeks babies. And we also learned that there were some outcomes that improved more and some outcomes did not budge. The devastating lung disease did not budge during that time. The brain bleeds did not, so babies still were continually having severe intracranial bleeds. And one can argue that that's not the right way of looking at it. So Mark Beltempo, who is a neonatologist at Montreal, is working with us at our center for this year, and he's here. And he looked at, from the quality improvement perspective, looking at the control charts, because this is the best way of realizing whether anything is happening. So you can see, even though our baseline is 93% survival, which is a very hard number to get anything better, we are still starting to see the common special cause variation that is happening in the babies for the survival, and survival without major morbidity is even crossing the special cause variation boundaries. So, and that is happening in individual outcomes. So bronchopulmonary dysplasia is coming down in the country, late onset sepsis, infection is coming down, the brain, the white matter lesions in the brain is coming down. There are certain outcomes which we haven't made progress, and those are the targets for the upcoming next sessions. And we made significant progress in small babies too. This is the survival without major morbidity at individual gestational ages, and you can see it is showing significant improvement, even at 31, 32 weeks, where our current rate is more than 90%. However, our real achievement, as I started to say, that we want to bring everybody together. So to orient this graph, this is a standardized ratio. So on the y-axis are the standardized ratio that's observed over expected. So 1 being number of adverse event is same as what you would have expected from the characteristics of the neonates that you care for. And anything above 1 means you have a higher rate. Anything below 1 means you have a lower rate. And the funnels are the 99% confidence interval. And we're proud to say that all 30 units are within that funnel. So everybody has come to that narrow band of confidence that outcomes are not different in individual units anymore. If this chart would have been completely different in 2010, where we were all over the place. So this is what we have achieved up to 2013, and without letting it guards down, by this time, many international people got interested. They were coming to our meetings, and they were coming, and units were coming from different parts of the world, and they come say, yeah, you are doing good, but I had no infection in my neonatal intensive care unit for last 1,000 days. And we say, what? This 3 years without any infection in the babies that we care for. And we said, if they can do it, why can't we? So we aim for driving it to 0, building on the concept of what we learned from EPIC 1 and 2. In this, we are forcing our sites to go and see what is happening at individual other units, like units, unlike units, spend 1 day, learn from them, do a critical review of sentinel events. If a baby develops infection, they have to do the review to see why, what went wrong in this chain, what was not done that's supposed to be done. So this is ongoing with a lot of feedbacks and a lot of support to the sites. This is our website where we continually put a lot of materials, so sites can put material and sites can review it, and we feedback this output. So this is the national average. This is the one site, and we tell them, look, something is happening in your site. You need to keep an eye. Something has changed. Whereas here, we don't call them because they are better than the rest of the network. Here, the change is happening, and we just say that, well, keep an eye. It may be just a number, small number, whereas in the last panel, it's a random variation. So we can hope to see what is happening. So collectively, at a national level, we have achieved what we wanted to achieve. So I want to go to the next step of what is international. Nationally, we also learned and developed what we call follow-up networks. So every baby is being followed in the same parameter across the country for when they are born less than 29 weeks, led by Ansenis. And the babies who are not born at the right place, which are born outside, is led by Kyung-Sun Lee from Sick Kids Transport Network, because we want to improve their outcomes too. And Eric leads the surgical network. We published our first outcome data at 2 years, and we now in the process of comparing it over the time period of the course. But with that, we learned that we need to work with obstetricians. If we get babies in good shape, then the outcomes would be better. So we have developed another network where we are now linking with the 24 maternal fetal medicine unit across the country, and we will be working with them so that they get antenatal steroid, they get deferred cord clamping, they get magnesium sulfate. So we get babies in good shape and ultimately improve the outcome. So this network has just been formed, and we will be working towards leading in the next 5 years to improve outcome, even from that level down by another 15 to 20%. But as Dr. Dostin mentioned, I will talk a little bit about international network because this attracted a lot of people to come and see what is happening in Canada. And it started with when we had a fellow from Japan, Tetsuya, and he said, well, you guys do things differently than what we do in Japan. And we were learning Japan's outcome data from papers that they had better outcomes. And we said, well, show us the data, and we compared. So we looked at the data from Japan and us, and we found really that they were good in 25, 27, 26 weeks. Whereas when it comes to the bigger babies, we were better. So they say, what? How can you be better? And we say, yes, because you're concentrating on smaller babies and intensively going after them, you're ignoring the other ones. And when we compared different outcomes, there were some outcomes we were better, and some outcomes they were better. So we both had to learn from each other, and we had teams going back and forth. And similar thing happened when we compared our outcome to Australia. And with that, I was fortunate to put together a group of committed individuals at this international networks. So now it has spread to 13 countries, and they are contributing data, and all those 13 countries' data are coming to Toronto, where we analyze and we look at what is happening. So this is again the standardized ratio, and you can see Japan outcomes are better, Switzerland and Sweden outcomes are better, whereas Australia, Spain, Canada, they're all within the boundary, and UK had worse outcome amongst all, including Spain too. And that was an eye-opener because everybody feels when they don't look at other data that they are better than others. But this led to them, okay, what is happening? Is there something wrong with the data? That's the first question, right? Everybody say, oh, no, you got the wrong data. We fed back. It is not data. It is something happening. And this is the picture that tells. So survival at different gestational age. We only started at 24, and I can tell you that Japan is going for 21 weeks babies now. But look at the variation. Your probability of surviving varies from 35% to 75%, depending upon where you are born. And that gap continues even until at 29 weeks. It narrows, but it continues because there are more babies, so numerically that would be more number of babies. And everybody looked at that and they said, oh, what is happening? Is there a policy? Is there something we are doing? And then we compared and look at the Japan. Still remains high. They are better in terms of survival of their babies. But when we looked at other outcomes, they are worse for their babies developing severe ROP. The babies developing bad eye condition is significantly high in Japan. So they also need to learn what is happening. It's not that one country is better in everything. And you might have seen the switch that happens in Switzerland and Sweden as well. And we are in the midst of evaluating why, what is happening. Is that something we are doing to the babies? How do we start these babies, or how do we get these babies, and how do they progress during the course of illness? And those are the things that are going on. Just an example, what people start in oxygen. I mean, we used to start 100% oxygen to resuscitate babies when I started my fellowship. Now we don't give oxygen at all. We start with the room air. And those are the things we learn and how others are doing. This is a fortunate group that I'm privileged to lead. But what has happened with that quality improvement, it has spread. So these are like people coming to us, and now not only Canada doing 30, the South American units, 24, are running the EPIC 11 units in Sweden. They call it SWAPIC. 24 units in China, 38 units in Malaysia, and 28 units in Australia has embraced this concept, comes to our meeting, presents their data, takes information, goes back, and does the quality improvement activity. Just to give you an example, this is from Professor Yun Kao and Xiyan Jiang. They are running a 3-year cluster randomized trial as we ran, and what they are finding, they're in the midst, but they are also finding that infection went down by 33% in the units which have started to do evidence-based practice implementation and quality improvement. I'll skip the slides. So we basically understood that we have to work together. We need to learn from each other. We need to see what others are doing. However, there were a lot of challenges. People do not understand QI. They always equate it to the research. And to understand that this is not outcome, this is process and outcomes. And to differentiate between process and outcome is the most important aspect. In addition to that, cohesiveness, keep people interested, because if you keep on badgering this, there is always a phase that your outcomes will go worse again. And funding is always a challenge. But one of the biggest challenge in the quality improvement is people's resistance to change. They think that they are doing the best and they will not change the way they are doing. But we have let people know that this is constantly changing. Next month, I'm going to Japan, where there is a unit where there is only 22, 23, and 24 weeks babies are being cared. The babies start with 340 grams, 430 grams, and they are there for months and months. So we want to see what they are doing and learn. Because if you improve outcome at the lower age, it has a ripple effect in improving outcome. So I hope in my time, I want to conclude that QI can achieve steady improvement in outcomes. It doesn't have to be an expensive, extraordinary material that you need to do a costly randomized controlled trials. However, you need to have supportive evidence from such high quality trial. I'm not here to bash randomized control. They are the panacea of what we do. But there are certain things for which we don't have evidence. We need to learn what is the best evidence available now and involve people immersively at individual places, individual units, learn from each other, and that will improve the outcome. And networking in this era is the key to do the QI. So I'd like to acknowledge a few people. These are the team that continuously work and churn the data and feedback the units. A lot of individual site investigators, not only in Canada, but 397 NICUs across the world, which have been sending us the data, which probably covers around 20% of the population. And we are now starting to work with India as well to make some changes over there. And with the last slide, I would like to leave you that I told you that this is what was our aim, and I hope we have reached to this stage. Thank you.
First question, Selfie.
Prakash, wonderful. And you know, it's delightful to see how far things have come from when this was started. So how much disaggregated information do we now have for Canada beyond, you know, just the aggregates? Do you have data by, for example, ethnicity, socioeconomic gradients? How much measures of inequity can you link to the wonderful data that you have?
Yeah. So thank you. Yes, we have that data. So what happens is that the neonatal data collection doesn't occur with a consent, because if we go for consent, the babies would die within 15, 20 minutes. We were never going to get consent. So we have embraced the concept of implied consent in the neonatal period. But when they come to the follow-up, when we see at 2 years of age and stuff, we ask all these questions. So socioeconomic status in the sense of ethnicity, first caretakers detail, employment, education, how many hours they spend, how much they spend. We are also going to lead another parent-led quality improvement, so how they can work with their child after the baby is discharged. So we have that level data on an individual basis in Canada. Other countries do have data, and I'm working with them to see. Ethnicity is the most difficult one, particularly in Toronto, I can tell you. I got a funding from my dean's first grant that you start as a faculty, and they give you fund, and I went there and I said, so what do I classify? The father is from Poland. Mother's father is from Poland. Mother is from West Indies. She says, what do you want me to tell my ethnicity, kind of thing. So we had to shrink and divide and stuff. But it is possible in other parts that does not have this varied degrees of racial differences, kind of thing. Because mother comes from two different sources, father comes from two different sources, and it's very difficult to say what the child is when it comes from four. But employment, education, the time provided, all those information we do have.
There's a question in the back. I can't tell if it's Devin or Margaret.
Devin.
Thank you very much for your presentation. That was fantastic. I'm curious if you can elaborate a bit more on how you navigate the issue of confidentiality in terms of sharing data between sites and within countries and beyond.
Yeah. So let me start with the national first. And so the issue of confidentiality was dealt with, one, the data sharing agreement, two, talking to individual hospital lawyers on a monthly basis and making them understand that I need a date of birth. If I don't have date of birth, I can't calculate anything. And then they started to slowly realize that, yes, this is needed. Plus giving them the confidence that data will stay at the coordinating center, will not go anywhere else unless instructed by them at individual site or given permission by their research ethics board. So they are in the safeguarded. For individual projects, we give data to individual person, but we need individual approval from individual REB. And that's why we rather say that you come here, do your analysis, and take aggregated data rather than that. For international, it was another navigation with the international laws, and the toughest one being the European laws. However, the people that are working there were able to convince their authority that, look, we have done what we needed to do. So what the international data comes after they have evaluated their own data, they have done what they needed to do, they have disseminated their report, and now it is sitting somewhere. And then they send. So it took a long, 24 lawyers in 12 countries was not a small task, but we have managed. And with understanding, we're telling them that, look, I'm not going to go and find that 23-weeker in some remote village in Sweden. I mean, that's not the idea. Here we want to learn from each other. We were fortunate in, I would say 20 to 25% of the cases, the lawyers had some experience with neonatal intensive care unit. And that speeds up the process.
There is a question in the third row right here. Yes, please.
Thank you for the presentation. It was really wonderful, and I'm excited that you're expanding into India, since that's our country of focus at CGHR at St. Mike's. I do have a question regarding Canada. How much has the delay, I noticed where the NICUs are placed on the map, how much is the delay to accessing NICUs for those who do not live around the NICUs played into the differences in the outcomes between the neonatal care units?
Yeah. So thanks for that question. So what we did was we looked at the differences in the urban and rural, because it's very difficult in Canada to say that, because we went through from the maternal postal code and where she lives and where she delivered. So we calculated the distance that way as to how far they are living, and then classified them into two groups, urban and rural, rural being more than 100 kilometers away from a central unit and stuff. And what we found was that that's the beauty of the universal healthcare system that we have, is that there are only one or two outcomes that mattered, and most importantly, one that allows parents to be there in the unit and allows parents to give milk for their baby. So the necrotizing enterocolitis, a devastating gut condition, is increased. It was higher in the babies who are born to the mothers with the rural residents, because they were not able to come to the unit frequently, bring the baby the milk. So we had to use either formula, or now we use donor milk kind of thing, but previously formula, and that affected that outcome. Infection was on a borderline stage where the infection could be higher, because nowadays in many of our NICU, it's the parents who take care of the babies. And when they are there, they are the police. If somebody walks in intensive care in their incubator without washing their hand or cleaning their hands, they will not tell that time. Sometimes they will, but they will tell that, look, 3 times this happened, and we try to prevent that breach happening. So infection was another on the borderline, not significant, but was higher in those who were in urban residents, so that those mothers were closer and they were visiting and staying with their babies. But other outcomes were not different, and probably it reflects that we have the universal healthcare system. So once your baby is in my unit, I don't see that he is from a lower socioeconomic status or higher socioeconomic status, because it doesn't matter. I provide the care. It does matter when the baby goes home and stays in the environment and comes back at 2 years. That's where we started to see the difference. But by the time you were discharged, there was no difference in the outcome of those babies.
I perhaps can't see all the lights. Does anyone have another question? Otherwise, I have a couple of questions. So one of the questions I have, Dr. Shah, is related to the types of populations that we often deal with. Now, you say you are dealing with India. Of course, India is many countries within a country, so you will have, I assume, neonatal intensive care units that would look relatively similar, perhaps not to the one in Mount Sinai, but perhaps to the one at Sick Kids. Yet in India or in many of the sub-Saharan countries, you have either district hospitals or the next level up, where the facility and the quality of care provided to the infants is nothing like we have here in Canada. So if I were to challenge you to say, if you were to start a network of quality improvement among those types of hospitals, where might you start?
Yeah. So thanks, and that's that you may. I mean, I think you touched a point that why this high-income countries are in the international INEO network kind of thing. Because we started with the premise that we need the data on a national scale. Because if you take 5 hospitals, they will come out. They will be the ones that are doing good, and they will give you the report, and they will be looking fine. So we started to learn that is there a variation, and how much of this material that we can translate it to the countries. I mean, China, it's not 24, they have 240 NICUs across the country, and of varying the capacity kind of thing. So they invited them and say, okay, but who wants to be participant of it? And I mean, the graph that I skipped, the control sites are the sites where the infection level was low, and the intervention sites were the high when they were randomized kind of thing, at the baseline. So it's a stepwise process, absolutely. I mean, I have been to India and went to all the NICU. I mean, I'm not saying that in India we are doing it at a massive scale. It will be initially started at the JIPMER, Chandigarh, and they will be leading the 25 to 30 NICUs that have agreed to participate, both from the government sector as well as the private sector. It's also there. Also, it's a competition. I don't want to give my outcome and then somebody knows about me and it will be financially not rewarding kind of thing. So it will be a stepwise. And I think once people see the results, once people see the feedback continuous, that's where other people get interested and then join. So in all those places, wherever we go, we have curtailed down the database to minimum data set. We said you don't need to collect thousands of variables that we collect. If this basic 50 items that you collect, and work on those items to make sure that babies are not cold, to make sure that babies are not, the infection rate is going down. Probably that will have a lot more to gain than going after bronchopulmonary dysplasia or donor milk and stuff like that.
May I ask you just a practical question? This is an immense network that started with a relatively small network. Where does the funding come from? I realize the CIHR is a major funder. And can you describe a little bit about the activities of the center in Toronto, which receives, I assume, massive amounts of data from both within Canada and around the world? What's the process and who pays for it?
Yeah. So we first of all, we were fortunate to get the CIHR. So the first, when we started in 95, 96, it was funded by the CIHR for a 2-year project. So at that stage, we were able to garnish 16 units to be part of it. They were around 22 at that time. And 6 said, well, we're not sure and stuff like that. We collected data for 2 years. After 2 years, and we paid, because CIHR allowed us to have the money to pay for them. And after 2 years, we said, look, this is the output, this is what annual report, this is annual report, and this is where your site is. We don't have any money now. If you want to continue, we will continue. So in 2001, there were only 5 sites contributing to the data because they could not have a local support to do that. So that's where we started writing the quality improvement guide. So the EPIC 1 was also a CIHR funded project. EPIC 2 was also a CIHR funded project. But we made sure during that process is that we're not paying for data collection. The unit has to take that ownership, that if they want to be part. And what happened at the same time was benchmarking was becoming kind of a norm from the administrative level. They were looking at saying, okay, how are you? But how are you in comparison to somebody else? So administrative aspect was also demanding that you compare yourself to other, and we provided that platform. We said, you collect the data and we will give you that data. So it was a slow uprise of number of units coming up. So by 2004, we have 24 units, and now after 2010 onwards, we have everybody, because everybody looked at it and say, why are we left out? So locally, the data collection is local sites' responsibility. What we get the funding and what we use funding is for the central data management support. And I was fortunate to get the chair for the INEO, which will finish next year. So it's a next process that we will be writing another grant to continue the activity with the background that we will show that this is what has achieved. Internationally, I would say that we have achieved to understand what are the differences. We need to take to the next step that, okay, how can we do the QI in this even a high-level countries? Some countries have bought in the concept, like Australia and Sweden. Others are still, well, we are good. And they're now starting to learn that, no, we are not. There is next door country who is better than us, and why don't we learn from them and go there? So, without me knowing, there are teams of international network, like collaborating partners. Like there was 15 people went to Japan for 10 days and stayed in their unit for 10 days to see what they do and how they do it. So people have been just connecting themselves without us knowing it.
I have more questions, but I'm happy for the audience to participate. Yes, the back row. Press the button on the, thank you.
Hi, I was wondering, and obviously understanding the principal focus is on neonatal care, if there was any research being done into prenatal care and how that influenced the neonatal outcomes in terms of, you mentioned the global report on preterm birth and how that was related in terms of prenatal versus neonatal care.
Yeah, so that is exactly what we realized 2 years ago, that as far as once the baby is in our hands, we have done a lot more things to improve. But now we need to see that there are things that we can do before the baby is born so that they come in a good condition. So with the help of CIHR, we launched last year and we got the funding. It's what we call a preterm birth network. So 24 maternal fetal medicine units and us are now joining force. And the neonatologists are leading to tell or train obstetricians how to do quality improvement, what can they do, what can they do to make sure that everybody is getting antenatal steroid? What can they do to make sure that there is a placental transfusion that is happening? There is no rush to rush this baby from the mother and stuff. So those are the steps that or maternal antibiotic use is another thing, because they don't think that they just treat the mother in front of them, but it has a bigger implication for the baby down the road. And we tell them that, look, you need to be judicious as to what. So those are the things that we will be working on. So we realize that we have to go to the other side of the umbilical cord. Otherwise, we're not going to be better than what we are. So we are aligning that force with the maternal care people. And that is happening nationally with us. And even internationally, the Norway and other people are also now having the similar kind of concept. Australia already had, which is Perinatal Society of Australia and New Zealand. They meet every year. They basically, their meeting is obstetricians and maternal fetal medicine and neonatologists, whereas they don't have a neonatologist going to the pediatric meeting. They go to this OB-MFM meeting to learn that what can we do so that we give you good baby so that the outcomes are better.
You've answered this question in your talk, but I'm going to ask you once again because I still have a little bit of trouble getting around the concept that quality improvement is not the same as research. There must be some parts of quality improvement that one has to do research to identify how to improve the quality of something. So again, could you spend just a moment, once again, talking about the difference between a quality improvement program and a research program? And it has practical implications because the need for research ethics board approval or individual approval from a subject or a parent is different, whether it's a quality improvement project versus a research project. So if you don't mind, one more minute on that.
No, I can spend a lot more time. So, okay, so I may have given a wrong concept that quality improvement is not a research. Quality improvement needs to be understood and researched in a different context and different measure than traditional research. So what we do in quality improvement, just to give you an example, at the moment, the best example I can give you is when the babies are in the small babies like this who cannot feed, we give them the feeding by the nasogastric tube. So we put a tube and that stays in the stomach, and we slowly give little milk to this baby on a regular basis until they are capable enough they can suck and swallow on their own. So when we do that, some of the units are checking before giving the feed what is left. And some units say, no, we don't want to check. Baby should be able to digest, and it will just process, and it will go. So that is what and at the moment, we don't know what is the best answer, what is the best practice to do it. And but current evidence suggests there is no better method kind of thing. So one can do a randomized control trial on this topic and say, we are going to half of the babies, we're going to do it, and half of the babies we don't, so that later on we can have an answer. So that will take 3-4 years. Whereas in quality improvement, we know that some units have policy that they don't want to check. So they just keep on pushing. Like in Japan, they don't check. And they just keep on pushing so that they can get intravenous nutrition out of the baby and just baby on the full feed. So we will basically be doing kind of a quality improvement project in the sense that, okay, well, let's get information first. How many are doing it, how many not doing it, and what is really happening when they say we don't do it, but is it happening and stuff, and compare their outcome. And then say to the other guys that, look, this is better strategy. How can you do a cycle of planning, doing, studying, and acting so that it completes the whole quality improvement bridge to say that we have made the change based on the evidence that is out. We could do randomized control trial and wait for the evidence, or we can say that, well, there is equipoise, we can compare this in a comparative effectiveness kind of fashion or setting.
Thank you for that really clear understanding. So are there any other questions? If so, yes, there is one up there, and two, actually. But let's start up there.
Sure.
Yes.
Thank you, Dr. Jha, for that wonderful talk. I had a question about the comparability of the different facilities between the different countries. So, for example, comparing to Canada, where it is a public facility and there is health coverage for these moms who are going to deliver, are the units comparable in that sense between the different countries?
Yeah, so there is always difference.
Yes.
Okay, but all 11 countries, there is one country which has a mixed coverage model, which is Spain. But the rest of the other countries have universal healthcare system. And that's why you saw that there is no US in this mix. And we tried, but again, the privacy confidentiality did not allow us to get data from the US in any sense. So that's why we're still working with the US to do it. So there are differences in the unit. We just looked at as to even how the babies are being cared. I mean, there are 20 to 30% of the units where each baby has their own room. whereas 80% are in one massive hall and 30 babies are sitting there kind of. So we're trying to see that what are those practice variation, unit like physical structure variation, the numerical variation or practice variation, and then link it to the outcome. So those are the next steps that in the INEO we'll be doing. There is no way I can stay here and say, no, every unit. You saw in the Canada, we have a unit with less than 100 babies and a unit with more than 1,000 babies. So there are differences, and we need to learn that is 1,000 the right number, is 100 the right number, or somewhere middle is the right number.
I just wondered if you could speak a little bit to your experience in terms of leading this kind of initiative, and what challenges you faced in terms of implementing it in resource-constrained context, both in Canada, and what hurdles you foresee in trying to bring it to other resource-limited contexts internationally.
Yeah. So in Canada, as you saw, we started with this. We put the invite in the first project to all 25 units, and only 12 willing to participate, because at that stage people were saying, well, we don't know what you're doing, and how can this make any difference and stuff. So one of the challenge was that people to understand what is quality improvement and how it can be done. And so what we did for that was we provided annual workshop of at least 1.5 days. So the unit where people will come from, the group of the people will come from the unit, sit together and work on one topic, to develop that topic and take back and then work on that to do the quality improvement change. The second one was privacy and confidentiality. So it was always a struggle, and sometimes some people were taking the quality improvement initiative to a level that you need to get a consent, because it's a fine line. I mean, how your unit sees this particular activity. If I want to change something, and if that is being changed is seen as a research, then they will ask for consent, and that delays the process and slows down the process in an individual unit. The other one was administrative challenge. So when in our annual meeting, when the unit comes, presents what they did last year, they give 6 to what are the activities, what are the quality improvement cycles they've done, and then they go back to the other units, go back to the unit, and then say, we need a quality improvement nurse in our unit, because this unit has done fantastic because they employed somebody just for the quality, and that made the biggest difference kind of thing. So administrative, what is EPIC? Like what and stuff. So 2 years ago, we had a meeting with 8 administrators from different units. Without us being calling, they came. They said, we want to learn, because these people are coming back and saying that, we need to do this because EPIC says this. And they came, they learned, and they said their eyes opened up, and they said, now I know when they come to ask me what is needed. So what few leaders in this group are doing is that go to the individual hospitals where they are finding challenges in implementing this, and go do the presentation, meet with the senior administrative officers, and then convey them the message that this probably will save you more money on the down road rather than what you are spending right now. So those are the things. When I take it to the international, there are 400 heads, and I'm not sure what will happen. So we are having another meeting, a face-to-face meeting in Toronto with the PAS meeting next year, where two days we'll put people in the room and come up with something until they can leave the room, and then see what happens when they implement.
So Prakesh, one big question is really how can this contribute to to global newborn survival? So as you know, the Every Newborn Action Plan has a quality of care framework linked with it, but it is much more focused on perhaps just ensuring availability and key
Access.
interventions, as opposed to granularity that you've shown in your work. What is the dialogue between your network, if any, and WHO in terms of linking to those kind of initiatives?
So at the moment, we haven't been, but Shu has been working on it, so I wouldn't say that it is me. So what has happened is that what he has initiated is healthy life trajectory initiatives, so which I'm part of, 1 or 2, that is being led. And what WHO is being the collaborating partner with 4 grants that has 3 have been funded and 1 is being processed. So it's a Canada, India, Canada, China, Canada, South Africa, where the focus is that we start preconceptionally in this area, which are undergoing massive transformation from the from economic perspective, from the people's practices perspective, and are at the verge of heightened non-communicable diseases. So China, we are running a randomized, it's part of a randomized controlled trial, cluster randomized trial. In India, it will be a 3-arm cluster randomized trial where preconceptional intervention, and all this would be coordinated by WHO's coordinating center. So with them being the key source, Canada funding partially and half of the funding coming from individual countries, we hope to see that we can make some inroads even before the mother is becoming pregnant. And in terms of how this can apply to the bigger survival, neonatal survival piece, I think people have to take this kind of information, because the numbers needed to be huge in this initiative, and it may not be under control of individual, because this smaller tiny preterm babies are under control because they all only come to this place, whereas there is a wide variety of places that other babies like late preterm babies can go, or the term babies with asphyxia can go. And I think that needs to be taken forth, but we haven't detailed work with them.
This is an incredible example of how a network of talented, dedicated individuals around a topic have saved literally thousands of lives and improved the health of literally thousands of children born prematurely or newborn infants. And it's a great example of a model that I think we should be using with other age groups and other disease entities. And one of the reasons that we chose Dr. Shah to speak today is because he is a global leader. This is our Global Leadership Series. And certainly the work that you've done has improved the health and lives of children and thus their families, both in Canada and around the world. And for that, we're grateful to you, and we're very grateful for your wonderful talk. Thank you so much.
Thank you.